Open this session focused on research projects, a flavor of the existing industrial partnerships. My name is Maria Picchio. I'm a nuclear medicine physician working here in this hospital and in this university, and I'm chairing this session together with my friends Alberto Briganti and Francesco De Covelli, who is the director of radiology department. So we do not have that much time, so I would please invite Professor Ewan Gibb from Vancouver, who will speak about gene expression and molecular subtyping in GE cancers. Thank you, please.
Thank you. Yes, first, thank you very much for the invitation to come and speak to you about molecular subtypes in GU cancers. I am a bladder cancer person, so this is a little biased in that direction, but I'll try to talk a little bit about prostate towards the end too. So with a layperson in the audience, really what is molecular subtyping? And basically what we're doing here is we're using gene expression data to classify tumors which are fairly heterogeneous into groups that have basically consistent biology and clinical features. And much like you would use, say, Granny Smiths to make an apple pie, you might use luminal or basal characteristics to stratify patients to different therapies, perhaps chemotherapy for basal and surgery alone for luminal. So the idea of subtyping really stems from similarities between the tumors to the actual biology of the luminal layer of the urothelial layer. So you can see here that basal tumors have a lot of consistency with basal cells, whereas luminal tumors have a lot of consistency with umbrella cells. And that's not to suggest that either basal tumors originate from the basal cell layer and luminals from the umbrella cells, particularly, more that they're sort of adopting programs consistent with those cell layers. There are quite a number of different subtyping models, I think at least 8 or 9 now, so it's getting a little bit ridiculous. I'll show you a couple of them just to kind of give you a flavor for what subtype models look like and what we might do with them. For TCJ in 2017, they came up with a 5-class model. So you can see here that there's a luminal axis and a basal axis. For the luminal axis, there's luminal papillary, luminal infiltrated, and luminal tumors. And for the basal, there's basal squamous. And they also identified this unique group called neuronal, which I'll talk a little bit downstream. There's also the consensus model, and so this one's quite interesting. Because there were so many different models developed, a large consortium got together and decided that we needed a reference or gold standard so we could compare all the different models to some reference point. And so this one, again, you can see recognizes a luminal and basal axis, including luminal papillary, luminal non-specified, and luminal unstable, but also identified this interesting stroma-rich group of patients or subtype, which I think is partially due to the type of tissue they're using for their assay, which included RC samples, and I'll show you a little bit of data why I think that in just one slide. Finally, they also recognize this neuroendocrine class, which we'll go into some detail. So actually the discussion a little bit earlier about the impact of TURBT on complete response kind of got me thinking, and classically I last minute put this into the slide deck. So in previous work we've actually published a number of papers exploring the molecular subtypes of RC tissue after therapy, including chemotherapy and pembrolizumab. More recently we're doing this unpublished study so far looking at RC tissues with neoadjuvant atezolizumab here. And you can see using the consensus subtyping model that we actually identify a subgroup of patients here that are considered stroma-rich that actually have very, very good outcomes. Their disease-free survival is even actually superior to pathological response. So the idea here is that if you have a scar-like tumor or a stroma-rich tumor, the biology is so favorable that these patients might actually be able to avoid chemotherapy, avoid radical cystectomy if we were to do a TUR prior to removing the bladder. So the only commercially available assay right now is the one that we have on market. It's a genomic classifier recognizing 5 different subtypes. Luminal and infiltrated, they're both on the luminal axis again. And then the basal and basal claudin low are both basal type tumors. Basal claudin low are highly immune infiltrated. And we also identify the neuroendocrine-like tumors again. So this test is designed to do 3 different things. Predict the risk of upstaging, benefit from neoadjuvant chemotherapy, and identify these really high-risk neuroendocrine-like tumors. And so these are the tumors that are going to present like conventional urothelial carcinoma, but are going to have a clinical and biological presentation much more consistent with small cell or histological neuroendocrine disease. So a little bit on NAC benefits. So, we all know this is kind of a challenge point, really, because, the response rates and 5% benefit isn't super impressive. It's better than nothing, but the question then is, given the morbidity of giving NAC to patients, should we actually be doing this? And so in a lot of my work over the last couple of years, we have seen this luminal molecular subtype doing quite well. Has a much less aggressive clinical presentation, reflected by good outcomes. There's indication that luminal tumors are more likely to be organ confined and thus cured by surgery alone. And finally, we do have some data suggesting that non-organ confined tumors will receive greater benefit to chemotherapy. So you can kind of see where I'm going with this thought. To sort of test this hypothesis or build some evidence to support the idea that luminals could escape chemotherapy, we assembled this cohort we call NAC Meta with Yair Lotan at UT Southwestern. It's a total of 601 patients. 247 were treated with neoadjuvant chemotherapy. 354 were treated with cystectomy alone. We excluded neuroendocrine-like in this cohort simply because these patients have terrible outcomes even with systemic therapy. And then we used inverse probability weighting to balance out the two groups as best we could using their clinical features. So the downstream, you're not going to see patient numbers, you're going to see percentages instead, and that's why. So doing our sanity check, looking at the full cohort, this is just chemotherapy versus not. You can see that the net difference at 3 years is about 7%. This is significantly different, pretty much in line with the clinical trial data, so passed the first check. Then we do the subset, we look at luminal patients alone. Now we're seeing an actual negative net difference of 2%. Of course, this isn't significant at 3 years, so we're not seeing any difference in this patient population. Conversely, the non-luminal patients, we're still seeing a large difference of 10%, and this is significant on both UVA and MVA. To give you a little bit more evidence that this is actually, luminals are doing quite well, this is a novel unpublished cohort of 92 clinical T2 patients, all treated with cystectomy. There's no systemic therapy here. One of the statisticians who works on prostate did this, so the timeline's a lot longer than I usually do for bladder cancer, but you can see at 3 years we have a net difference of 20%. So again, our luminal patients with cystectomy alone are doing quite well, actually. So we can probably start thinking about avoiding chemotherapy for them. So next, these neuroendocrine-like, this is a topic I think quite close to my heart. I really find this quite fascinating. But a number of years ago, we developed a neuroendocrine-like classifier with Peter Black at UBC. And this is showing some validation data. So you can see in the little blue box above that these are the neuroendocrine patients, and they really robustly express neuronal markers, as indicated by the bottom panel. But they have an absence of basal and luminal markers. So they're very distinct and very biologically unique. And clinically, you can see this is a cohort of 234 patients, all treated with systemic therapy. Within 12 months, we have eight events. So these patients, are not doing well even with chemotherapy. And so it's coming back to my fruit analogy a little bit, but so these tumors, typically do present as conventional urothelial carcinomas. So you're not going to see them through routine pathological screening. They will actually stain for neuroendocrine markers if you go back and stain them, even though they look like conventional urothelial. They're quite recalcitrant to platinum, at least in our hands, for evidence we've collected. And there is no standard of care currently, but current NCCN guidelines recommend topocidin cisplatin for neuroendocrine features, and we'd like to imagine that this would be something we could consider as well. Also, so the benefit from pembrolizumab, this is another interesting study we actually did with Andrea. This is Puro-1, so this is neoadjuvant pembrolizumab. This is about 80-some patients, I believe. Which we had genomic data. You can see that models actually matter. You can see the consensus in TCGA classifiers. We both find these neuroendocrine-like patients, again, have these very, very poor outcomes. But, these two classifiers, it's kind of a nod. You're not really sure what you might do or not do with any of those particular subtypes with respect to pembrolizumab. However, using a Decipher classifier, we found that these patients with Claudin-low subtype, and these are the very heavily immune-infiltrated tumors, tended to have exquisite outcomes. We have 14 patients with only a single event after 3 years, and this is actually found to be significant in a more recent analysis. Finally, a little bit on prostate cancer. So This is a model that some of the team at Veracyte has been building out. They used consensus clustering and identified 4 different subtypes: luminal differentiated, luminal proliferating, basal immune, and basal neuroendocrine. And comparing it to the PAM50 models, this is your breast cancer subtyping model, we found pretty poor consistency with that model. But what's interesting is clinically, again, we find these luminal differentiated tumors, these are most consistent with the luminal papillary and bladder, actually have pretty good outcomes with prostatectomy alone, which is consistent, again, with what we're seeing with bladder cancer, with luminal patients with cystectomy alone, which is quite interesting. Finally, yeah, acknowledgement. So it takes an army. There's a lot of people. This is probably not even nearly everyone who's been involved in the bladder cancer program at the Veracyte since its inception. So yeah, with that, I take any questions, I guess.
Yes, Petros.
Thanks, Iwan. Always very insightful, and just to make the point, you're always great to collaborate with. So thank you for this spirit. We are here discussing with Lars and looking at the data you showed about the luminal. Mm-hmm. The question I have is, do we think about designing a study in the luminal subtype in muscle-invasive bladder cancer, and potentially patients with clinical T2 only and negative ctDNA, to quote Andrea? Could we show that those patients may be cured with surgery alone, without systemic therapy? But that probably trial will need a large sample size. Any comments on that? Do you think these may be the patients who may not benefit that much from neoadjuvant chemo? Obviously, for now, we're still treating them with neoadjuvant chemo, but maybe this is a population in the future that may spare them from chemotherapy.
Right. No, I think that's exactly where I imagine taking this. Unfortunately, the numbers required to run such a trial are in the order of about 1,200 patients. So we lose power rapidly. There are interesting statistical approaches we can do to kind of look under the hood as we're accruing patients, but it's not really as robust as we'd want to get that evidence to really convince people, I think, to withhold chemo at this point.
Iwan, great talk, as usual. You are already surfing the X wave already. A quick question to you. What do you think about the shifting molecular subtype before and after any systemic therapy in matched tumor samples? So you have experience in matching samples after chemo and after immune therapy. Do you foresee the need for reassessing the molecular profiling after any induction neoadjuvant or induction systemic therapies prior to making any decision on how to move forward, or consolidating therapy, or providing any suggestion for sequential therapy after the initiation therapy?
Yeah, I think absolutely. So, I think the ctDNA assays, we're also developing one ourselves at Veracyte, are critical to telling you should treat a patient, but it doesn't tell you what you should do. I think these different molecular subtypes, if you want to call them that, we're seeing it in the post-therapy setting of RC, could inform the next level of therapy. So, for example, the scar-like, we see very high angiogenesis signal, which could be ramucirumab we could think about for those patients. Or sometimes we see very heavy immune infiltration in terms of patients who have been treated with chemotherapy. So maybe those are the immune checkpoint inhibitor population we target. So there's definitely room, I think, to develop something with this data we've generated.
Just a quick question. Wonderful talk. As you know, we are working a lot with Andrea in our institution with the MR imaging of bladder cancer before and after immunotherapy. Do you think there is a role in combining molecular subtyping and the MR appearance of the lesions in terms of signal, in terms of infiltration, in evaluation, in prediction of response to chemotherapy or immunotherapy?
Yeah, absolutely. I think that subtyping, again, is a tool in the toolbox, right? So I don't ever want to imply that we should use subtyping as an exclusive decision-making tool, but it should complement your clinical variables as well for making these decisions, including imaging, absolutely.
Your comment, insightful comment. Looking at our data, as you know, we found an intriguing association between lower viral scores and luminal subtypes, suggesting that potentially we may predict the stage and may potentially in the near future predict the molecular subtype with the use of MRI. Mm-hmm. What do you think? There is an intriguing association between lower virus 0, 0, 1, or well, we defined actually 0, virus 1, 2, or 3, and the luminal subtype. So just making any potential association between lower stages and molecular subtype and MRI. Yeah. So maybe overcoming the need for TURBT maybe in the near future, just making a biopsy on the tumor like English people are doing.
Yeah, that would be pretty amazing, absolutely. Because I mean, clinical T1s are generally luminal as well, so that kind of speaks to your idea that they may be smaller lesions in general.
Excellent, thank you.
Thank you.
So I think now we can move to the next presentation. This has been a fantastic talk. Congratulations. So the next presentation will be given by Dr. Ross, Foundation Medicine Comprehensive Genomic Profiling in GU Cancer. I mean, we all know Dr. Ross and his fantastic help and contributions in the field of genomic characterization of GU cancers overall. So we are very happy to have you here, and we had always great time together when you come to Milan. So
very much for the invitation, and I'm very happy to be able to speak ahead of Jeff, because speaking after him about biomarkers can be quite difficult.
we did it on purpose.
Thank you. Yep. Okay, can you hear me well? Yeah, hopefully now. So I will talk today about a novel target in the immuno-oncology space called GDF15, which is specifically developed for treatment of PD-1 relapse refractory tumors, and maybe one key resistance factor for checkpoint inhibitor treatment. GDF15 is genetically a member of the TGF-beta superfamily, but it's a quite remote member, and in that regard does not share too many features of TGF-beta, an example. And the actual full name is growth and differentiation factor 15, or MYC1, a macrophage inhibitory cytokine 1. And it was discovered to be expressed actually under physiologic conditions, virtually only in placenta. So it has very little to no function in a healthy individual outside of pregnancy. And when oncologists hear that a molecule is highly expressed during pregnancy, and in the placenta, they get very excited usually, because molecules that play a key role during pregnancy very often are hijacked by cancer and actually sustain cancer mechanisms. And we believe that the same is true for GDF15. To give you one example how critical this molecule could be in fetal-maternal tolerance, these are the serum GDF15 levels over time during the first weeks of pregnancy. We have a second speaker in the room. I'm just not aware where that person is. And what you see here is actually a very dramatic picture. The white bars are healthy pregnancy. In other words, if you have a viable pregnancy in the first 3 months, you must have elevated GDF15 in your serum. If your serum levels are low, you will have a miscarriage, full stop. It's a black and white picture. And the question naturally, is there also a mechanistic link here? Because naturally such a picture for a biomarker could also occur that the biomarker is basically just the passenger and not the driver of the process. But we have done research in the past years in our company and with our academic founders of the company I work for, Catalim in Munich, that has shown that GDF15 is a critical molecule for immunosuppression, and this mechanism has been hijacked by cancer cells to create a local potent immunosuppression which is similar to the immunosuppression we see in pregnancy. And in that regard, there are a lot of similarities between fetal-maternal tolerance and pregnancy, and basically placental growth and conditions versus what happens in a tumor. And you can imagine that if a genetically different organism grows in a person, that the immune system of that person needs to be suppressed, because otherwise this organism would be rejected on the spot. And in that regard, the immune regulation in the placenta is a super sophisticated situation, and in that regard a lot of important molecules are involved in regulation of immunosuppression in the placenta. You know some of these molecules from oncology, PD-ligand 1, an example. Was that a question? No. CTLA4, TIGIT, TIM3, they all actually are present in the placenta. And GDF15 is too. It's actually expressed by trophoblasts and has a very potent local immunosuppressive activity. And one additional feature, by the way, of pregnancy is the so-called hyperemesis gravidarum, which is this feeling of nausea and emesis during the first months of pregnancy. And interestingly, this is also caused by GDF15, and elevated GDF15 has been shown to basically act on a receptor in the brainstem called GFRAL. And this signaling through GFRAL in the brainstem causes nausea and emesis. And this is the case during pregnancy, where the serum levels reach these levels for nausea and emesis. But this is also happening in cancer. When cancer cells produce high amounts of GDF15, you get to levels that via the GFRAL receptor induce nausea and emesis. So part of the cancer problem of nausea and emesis and weight loss is caused by GDF15, which here is actually produced by the tumor itself. So we have learned so far two things. First of all, GDF15 plays a critical role in fetal-maternal tolerance, but we also know that it obviously plays a role in hyperemesis gravidarum, which is basically one way to reduce weight if you're continuously nauseated and do not have appetite. But this has been hijacked by cancer in the sense that elevations of GDF15 through tumoral GDF15 result in the same picture, which leads to cachexia in late-stage cancer patients. So we know there is an immunomodulatory role of GDF15 and there is a metabolic role in cachexia and anorexia. But the big question is, if cancer induces cachexia via GDF15, what about the immunomodulatory role of GDF15? Is there an immunosuppression by GDF15, yes or no? And in that regard, we investigated further what tumor types express GDF15 and what it does in the tumor itself. And first of all, it's expressed in a wide variety of tumors. Just to give you here an incomplete list, it's actually meanwhile more than 20 solid tumor types that have massive overexpression of GDF15 demonstrated. And interestingly, on top of the metabolic function, it also has an autocrine tumor promoting factor role, where you basically have migration and invasion enhancement, and you also have the ability to induce resistance to therapy. And one mechanism how this works and how this is used by tumors to also create an immunosuppression is shown here. And this is actually work which was published earlier this year in Nature Communications by the University of Würzburg, Jörg Wischhusen, our founder, and Catalim employees. And what you can see is what happens in inflammation. You have basically a tissue that is inflamed, cytokines are secreted, and then the T cells and immune cells in the bloodstream are basically adhering to the endothelium. They start rolling, and the LFA1 ICAM axis is induced and then basically results in transgression into the tissue, and the immune cells can address the infection. And interestingly, cancer uses the same principle to get rid of this, because cancer cells do not like to have immune cells in their presence. And the way they do that, we believe, is one way is to overexpress and secrete GDF15, these little red dots, which actually leads to an inside-out signaling in the immune cells and creates the inability of the immune cell to adhere and transgress into the tumor tissue. And the logic consequence is, if there is no immune cell in the tumor, there is no response to immunotherapy. We demonstrated that in a quite sophisticated cell adhesion assay experiments, and just one simple experiment here for adhesion shows you that if you put an inflammatory stimulus on the other side of the Petri dish, you actually get a massive adhesion of immune cells. But if you add recombinant GDF15, there's no adhesion anymore. This has been confirmed in tumor models, in vivo models, where basically the immune cell infiltration is blocked by GDF15 secretion of the tumor. But if you block GDF15 with an antibody and you neutralize it, you actually get full reconstitution of immune cell infiltration. And in summary, the work we've done preclinically is shown here, and as mentioned, was published in Nature Communications in July. We could not only show that GDF15 blocks the immune cell extravasation into the tumor, but it also supports or basically blocks the generation of immunosuppressive cell types, M1 polarization example. It interferes with APC activation and maturation, and it also reduces T cell priming and differentiation. Consequently, it's very attractive to think about neutralizing GDF15. And this is what we actually did initially preclinically. And what you can see here is that's a mouse model with an orthotopic pancreatic cancer model. This model is kind of partially sensitive to checkpoint inhibitors. And you see that here, this is basically the control animals and the tumor size. And then you see that anti-GDF15 alone has a kind of mild tumor reductive effect in a few tumors. If you use an anti-PD1, you actually reduce a tumor size significantly, but if you combine the two, you virtually double the reduction in tumor size by this approach. So in other words, these preclinical experiments suggested clearly that GDF15 has an immunomodulatory function, not only in fetal maternal tolerance, by the way, also in tissue injury, something I didn't speak about today, but we see it now mainly in oncology as a key mechanism to prevent immune cell infiltration into the tumor and activity of checkpoint inhibitors. And consequently, we went into the clinic with an anti-GDF15 blocking antibody called visukromab. This was a presentation last year at ESMO 2022. And In this trial, we did a phase 1 dose escalation, knowing that the antibody alone would have only a very moderate anti-tumor activity. We did an immediate combination, so just 2 weeks of monotherapy for safety purposes, and then a combination with a checkpoint inhibitor. And this all, by the way, in checkpoint inhibitor relapsed refractory patients. And the relapse do we have lost the microphone? No? You can still hear me, good. So the relapse refractory status was according to very strict criteria. No patient from adjuvant treatment, no patient that stopped checkpoint inhibitor according to a protocol. So patients had to relapse, or if they had an initial response, become refractory on ongoing checkpoint inhibitor. So a truly checkpoint inhibitor relapse refractory population. And in this population, actually here we see just the PK and the neutralization. We saw some very interesting pharmacodynamic effects. But before talking about the pharmacodynamic effect, the question is, do T cell numbers in the... We have to change again, yeah. So in that sense, we first want to ask a question, do T cell numbers in the tumor matter? Are sheer numbers predicting anything? And in fact, they do. And this was shown in a landmark paper by Tony Ribas in Nature in 2014. They looked into melanoma patients and asked the question, if you respond to checkpoint inhibitor treatment, what are the CD8 counts in your tumor area? And they showed that every single responder of 13 investigated showed an increase of about 2 to 3-fold in CD8 counts in the first 120 days. And interestingly, the 33 patients progressing had 0 change in CD8 positive T cell number in the tumor. So CD8 positive T cell counts matter. And in that regard, we were very delighted to see that in our trial, we could not only see an increase in CD4 and CD8 counts already on monotherapy and in combination with the checkpoint inhibitor, but we also saw an increase in T cell proliferation and in granzyme B release. So very clearly indicative of an adaptive immune response getting underway. And this in checkpoint inhibitor relapse refractory patients. What did that mean clinically? Here is the dose escalation summarized. And you see on the first 2 dose levels, we didn't see much. Patients progressed very rapidly, mostly with the first scan, left the trial. But then we started to see partial responses. And one patient actually with a CUP tumor, carcinoma of unknown primary, very hard to treat entity, had only a single small lesion left after 1 year of treatment. There was a radiofrequency ablation done. And then this patient had for 6 months a complete response until another lesion actually started to grow. So for an early stage last line phase 1 trial, this was quite impressive activity, and we are further investigating that. Here, as you are bladder cancer specialists, this is a scan from a patient who was treated in 4th line with the experimental treatment with visukromab and nivolumab. This patient had received gem-cis, had received carboplatin atezolizumab, had received vinflunine, and never had anything beyond a partial response. And here you see that the patient over time developed a complete response. He allowed us to show his picture. And Carlo, he is a cyclist like you. And this gentleman did not ride a bike for several years under treatment, and now he's back to 100 kilometers a day. And I show this picture because this was his first tumor-free Christmas, and this year is going to be the second one because he's in continued complete response and does very well. So we see immunologic tumor control is really working and can change lives. We're not looking, for the sake of time, into too many other slides, but I want to give you an outlook, and this is a little bit the unfortunate timing here. If this meeting would have been on December 7, I could have shown you the real full phase 2 data set, which is amazing. But unfortunately, this data set is presented December 6 in Geneva at the ESMO IO meeting, where we show the data on the bladder cancer cohort and the non-small cell lung cancer cohort, where we see response rates in completely relapsed refractory last-line patients, which are significantly above what you see with an IO combination in such last-line patients, usually. So in that regard, we are very excited about this data, and I hope you can watch out for this Geneva presentation. And we will continue with randomized controlled trials, phase 2b trials in first-line indications from next year onwards. And we are very happy to work with Andrea on a neoadjuvant trial that we started a few months ago. And in that regard, we'll see where this compound goes. But I think it's a very clearly novel, active immunotherapeutic. Thank you very much.
So thank you so much. That was very... Is it okay? It's okay.
There's a question in the audience.
Great talk, thank you. Do you have any additional data besides the T-cell infiltration data on T-cell exhaustion mechanisms also, if that can be used to further differentiate the response in these patients?
Yeah, we actually have mechanistically additional elements of the Melman cycle analyzed, and actually these data are in preparation for publication, so that should come out soon. Yeah, definitely.
Huge and great presentation, and I think you get the best name for the clinical trial, the Godfather 1-2. I think it's similar to that trial at ESMO, right? I had a similar question with Lars about the potential of predictive biomarkers. Yeah. So, I know you may not be able to solve the data, but what do you think are maybe a couple of more promising biomarkers driving maybe in the patient you saw with a durable response? What may be the driver of this in outlier patients?
This is a very, very important question, of course, in the focus of our development. The one thing we noticed is, we operated so far in late-stage relapse refractory patients. And interestingly, we feel that some biomarkers in such a setting almost completely lose their context and their importance. Because you have a completely deregulated translation and similar in the tumor cells. We have, fortunately, a huge translational research data set where we noticed, and this again is fortunately in bladder cancer, where we saw in a huge bladder cancer collective that actually, in example, serum GDF15 levels in first-line metastatic bladder cancer, patients correlate one-to-one with the CD8 infiltration, with the T-cell activation, and in that regard, in the tumor. So basically, we have tumor tissue correlated with serum. And in that regard, we believe that in a first-line trial, serum GDF15 could potentially be a biomarker. We also investigate in parallel classic markers like PD-Ligand 1 and others. And we see responses at the moment in PD-Ligand 1 positive and negative patients, so this may not be a decisive factor, but it naturally may have an impact, of course, in first line on the checkpoint inhibitor, which comes along. So in that regard, this is under investigation, but we are not yet there that we can answer all the questions. Thanks.
So, thank you very much. It was a very nice presentation. Now it's time to call back to the stage. Jeff, are you okay now with the slides? Excellent. So we are again very happy to hear your presentation.
Molto bene. Thank you so much for allowing me to be here again. Io sono onorato to be a speaker at this wonderful symposium. My topic is actually focused on tumor mutational burden. Since the immune checkpoint inhibitors first started to demonstrate their efficacy in 2015 in the public arena as well as in clinical trials, the search for biomarkers to help decide which patients might most benefit from this form of therapy began. And among them, tumor mutational burden, or TMB, was one of the first. When it first appeared, there was great hope that this could be a very specific predictor of outcome, and the early data was very focused on single-agent checkpoint inhibitor treatments. More recently, combination therapies, especially chemotherapy plus immunotherapy, and even more recent, the antibody-drug conjugate plus immunotherapy, have really continued to make TMB an important biomarker of consideration. I'm going to talk about it in general and then swing and be very specific for urothelial cancer, for penile cancer, for renal cell carcinoma, and prostatic carcinoma. So what is TMB and what isn't TMB? TMB is a precise calculation of the number of non-driver mutations, non-germline mutations, non-germline SNPs that are measured from the genomic profile of a patient who's had sequencing for care of cancer. It's important to understand that if you get a report of the genomic alterations and you count them up, the drivers, P53, CDK12 in prostate, VHL in kidney, none of those are included in calculating the TMB. We often have physicians call up and say, there's 12 mutations on your list and you said the TMB is only 1, you've made a big mistake, and we have to constantly remind that the driver mutations on the report are not included in the calculation of the TMB. It's virtually a calculation of the variance of undetermined significance. But these are believed to produce neoantigens that immunize the patient towards their own cancer that's relieved or inherited when the blockade of PD-1, PD-L1 is accomplished with an antibody to either. One of the biggest issues with TMB testing is to understand that this is not like BUN or creatinine, where you can get an accurate result, whether it's done here at the Hospital San Raffaele, or done in Rome, or done in Budapest, or done in Chicago, where you can trust the BUN and creatinine at every hospital the patient's been tested at. This is not like that. It's a very sophisticated calculation based on an algorithmic assessment of a large amount of sequenced DNA. If not enough DNA is sequenced, you'll get an erroneous report. If the algorithm saturates at the low end or the high end, you'll get an inaccurate report. So it's very critical to do this properly, which means a significant amount, at least 1 million base pairs of DNA are sequenced. Probably it even should be 1.2 million base pairs, and that the algorithm is designed to calculate it accurately, and that particularly involves the filtering of the germline SNPs and not letting them be counted, because obviously a germline alteration is not something a patient is going to make a novel antibody against, because that's considered self. So TMB is not correlated with PD-L1 expression. You can have high PD-L1 expression and TMB of 0. You can have TMB of more than 20 and have no stainable PD-L1 in the IHC slide. There are correlations, and in general, a patient who does have a high TMB, over 10, over 20, and a PD-L1 in the high level, more than 50% staining, perhaps using the DACO22C3 assay, those patients do tend to have the most robust and durable response to checkpoint inhibitors. And obviously, in the other way, a TMB of 0 and a 0% staining by PD-L1 predicts a much lower likelihood, but not necessarily no likelihood of the patient benefiting in any way from checkpoint inhibitor treatment. Once again, a lot of this data is based on single agent checkpoint inhibitor use, not on combinations, and is predominantly retrospective. TMB is first developed as a biomarker in a wide variety of cancers. It was clearly shown early that certain tumor types that were exposed to UV light, melanoma, or cigarette smoking, lung cancer, and cigarette smoking, urothelial bladder cancer would be high TMB type tumors. And tumors that didn't have those types of etiology often were less. And the endocrine tumors, for example, were not frequently high TMB. Breast, prostate, ovary, those types of cancers. The work was early, but it's held up. There's not been much change. The early response data was provocative, was profound. It's New England Journal of Medicine publications about how high TMB was associated with single agent strong benefit from checkpoint inhibitors and low TMB was not. And this first important paper of over 5,000 patients validated that both for progression-free and overall survival. At the same time, research began and then emerged that you could also measure TMB in a blood sample like you could in a formalin-fixed paraffin-embedded tissue sample. There's a lot of issues, though, when it comes to blood-based TMB. Is it accurate? That depends. What does it depend on? Depends on how much DNA you were able to extract from the blood sample in the first place. If you get a low DNA yield in your extraction, your TMB measurement's going to be far less accurate. And below a certain amount of ctDNA, it's not possible to report the actual TMB for that sample. On the other hand, as a larger amount of tumor-based DNA is extracted from blood, the accuracy of TMB in blood is very high. Now, one thing always to remember is you just can't compare blood-based TMB to tissue-based TMB in the same patient unless both samples were obtained on the same day. If you do the blood TMB weeks after you do the tissue TMB, you may have put various types of therapy, including radiation, systemic chemotherapy in place, all of which influence the TMB. TMB is not a permanent measure of any individual patient's cancer throughout its lifespan. It's a dynamic assay that changes over time and tends to increase as more lines of systemic therapy are given to the patient. So you can't use next month's blood TMB to say that the patient's tissue-based TMB was wrong or vice versa. They're measuring the disease at the time the sample is taken. The early blood-based TMB was very focused on non-small cell lung cancer. That's where the first data came out to show that you could accurately measure it and that it would predict single agent, in this case atezolizumab, efficacy in non-small cell lung cancer. And it took a longer time to start using blood-based TMB in non-lung cancer type samples, including especially urothelial bladder cancer. But when it was finally done, both tissue and blood have both been very predictive in the single agent setting, but more emerging in the combination setting. Why the difference between single agent and combination? Well, we thought it was biology. We thought it was the cancer behavior. More recently, we think it's who did the measurement and how accurate was the TMB in the first place. We have studies out there who conflict and say that TMB is very good for single agent testing, but once you're going to use a combination, it's not so reliable. And you find out that the original baseline TMB was done on the tissue, and then the TMB was done on the blood to show that there wasn't a good prediction. It has to be done accurately in order to decide whether it's useful or not. And when we do multivariate analysis, we can see changes where PD-L1 will be the only independent predictor and TMB won't. But later, when we validate and standardize the TMB measurement in that particular trial, it changes and TMB becomes the independent variable and PD-L1 becomes not independent. So still a lot of work in progress in combinations, but I think an established utility for single agent. Well, we're going to do it in a second. We'll talk about EV plus Pembro. We'll find out. We don't quite know that yet. So whole exome sequencing was also used at the same time targeted panels by tests like Foundation Medicine or Tempus or Caris or even Guardant in the blood. The whole exome sequencing and whole genome sequencing was very predictive. The TMB predicted the efficacy of checkpoint inhibitors in single agent settings for melanoma, non-small cell lung cancer, urothelial bladder cancer, gastrointestinal cancers, especially colorectal cancer, and other tumor types with very impressive, as you can see, Kaplan-Meier overall survival curves. Oops, we're not moving. Here we go. So now we start to try to evaluate it in various types of combinations. And here's a list of many different trials which are looking at TMB in a combination treatment setting, which does include several urothelial bladder and even a prostate cancer trial. You'll see that there's no RCC, renal cell carcinoma trial, and we'll get to that in a moment. So let's start first with urothelial carcinoma, and this was among the first tumor types that linked TMB to prediction of checkpoint inhibitor outcome. And work was done by a number of institutions. I think Jonathan Rosenberg and Sloan Kettering was the first to publicly present the impact of TMB on checkpoint inhibitor outcome. But since then, many other sites have done that. This is a very recently published studies of which Shilpa is the senior author of, looking at TMB in urothelial bladder cancer with the so-called Flatiron Health Clinical Genomics Database, looking for real-world clinical outcome data, RWCOS as we call them, and this was a positive study that clearly did demonstrate the efficacy, but again in a single agent setting of TMB in the real world in urothelial carcinoma. Again, it requires accurate TMB measurement and understanding of when the sample was taken in terms of its ability to predict clinical outcome. We recently completed a study that went from an oral presentation that Phil was the first author of, but Andrea did the presentation at ASCO GU last year. And now we have the manuscript out or near out in the next day or two in JAMA online that showed the impact of high TMB in penile squamous cell carcinoma, showing an impact on efficacy of checkpoint inhibitors. We don't see very high TMB in penile squamous cell carcinoma. We have to temper it against the HPV status, but we believe it should be part of the workup of a metastatic penile squamous cell carcinoma patient in order to decide when and how to combine immunocheckpoint inhibitors with other therapies for these patients. And here's this study that's now emerging. For prostate cancer, we were hearing a little bit about that, and here's a recent study that we did in which Niraj is the senior author, which is really bringing the symposium together, again using the real-world clinical outcome data from the Flatiron Health to show that although high TMB is not common in prostate cancer, when you find it, which is often linked, believe it or not, to the Lynch syndrome, to prostate cancer, men who develop prostate cancer in a background of an inherited susceptibility. And it also is seen in BRCA1, 2, and other homologous recombination defect-associated prostate cancers. The BRCA prostate cancers will have the higher TMBs, but it's very rare to get one higher than 10 mutations per megabase, and virtually almost unheard of to see one more than 20. But now we see the data that if you do see TMB elevated in prostate cancer, checkpoint inhibitor therapy, certainly single agent at least, has been associated with clinical efficacy. And then last on the list, we come to the enigma, and that is renal cell carcinoma, especially clear cell renal cell carcinoma. I'm not saying that we don't have predictors of checkpoint inhibitor efficacy in sarcomatoid renal cell carcinoma, maybe in chromophobe and several of the other histologic types, but in the big major subtype, clear cell TMB in no way predicts the efficacy, which we know to be high for checkpoint inhibitors in RCC. And we've talked in many conferences, and I'm going to get a chance to publicly give my theory about this again for the 18th time, that it's not related to the immunogenicity of the DNA, the number of mutations, because renal cell carcinomas almost never have an elevated TMB and yet still respond vigorously to checkpoint inhibitors. I still believe that the reason they're clear is because of the lipid in the cytoplasm. That's why they're clear. It's not glycogen, it's a lipid, and that this lipid we know to be an immune stimulant. Lipid stimulates, that's why all our vaccines are dissolved in lipid. That's how we give them, because the lipid helps the immune response develop. And maybe RCC is just sensitive to checkpoint inhibitors because the tumor by nature stores fat in the cytoplasm and it leaks out and turns the immune system on. No one's ever been able to tell me that I'm wrong in that theory, so I keep doing it until someone proves that I'm wrong. But right now, we don't have any biomarkers. We don't have any biomarkers for just about anything in renal cell carcinoma, and we certainly don't have it to predict which patients are going to benefit from checkpoint inhibitors. PD-L1 staining, by the way, also non-predictive and rarely elevated. Let's not forget that we were talking about the serious side effects of checkpoint inhibitors. These are not just, non-toxic agents. And so having biomarkers to predict which patients will respond in all of the major types of GU cancers is critically important so that we don't expose the patients to toxicity with no chance to get efficacy or benefit from the treatment. Many new predictive assignments are going on. We haven't had any GU studies in which we actually try to rise up the PMB by giving some type of TMB stimulant like, they do in colorectal cancer with an anti-glioblastoma drug, as you've all read about, to try to increase the TMB, or local radiation to try to increase the TMB. But I suspect this is something we may try in the future to see how we could increase it before we give the checkpoint inhibitors to predict even more efficacy when they're administered. Cut points. We don't have GU-specific cut points. We have US FDA-approved cut point, which is 10 mutations per megabase. Any patient with 10 or more mutations per megabase is on label for pembrolizumab single agent in the US in the second line or beyond. But we don't have cut points for prostate cancer. Should it be lower? We don't have cut points for renal cell carcinoma. We don't have any, and we don't have cut points even for penile squamous cell carcinoma, although we used the 10 for our study. So this is work that's still ongoing, and maybe for urothelial, we need to have certain therapies for cut point at X, maybe 10, and a different one for 20, and eventually see that start to more personalize the new, what will soon be NCCN and world standard of care for first-line metastatic, which of course is the enfortumab vedotin plus pembrolizumab combination. We don't, as we heard, have any biomarkers that can really predict whether the antibody-drug conjugate is going to be effective. But we certainly do have biomarkers that predict whether the pembrolizumab, when it's a single agent, is predictive. Whether or not those will work when it's combined with an ADC, we don't have that data yet. So I'm going to end with two slides. There are current issues with TMB. Most of the predictive studies have been retrospective, but now many prospective studies have emerged. The prognostic versus predictive significance has been debated extensively. Personally, I don't find a lot of difference between those two, but some do. The different predictive values for single agent versus combinations are still to emerge. How to define and use cutoffs have not been fully proven. How to combine them with MSI status and with the PD-L1 IHC still being evaluated. What are the cutoffs with PD-L1 staining? And when you see TMB elevated, which category should you combine those two? And when best to combine them in the neoadjuvant setting, the adjuvant setting, the metastatic setting. And of course, in urothelial bladder, we even have use of checkpoint inhibitors in the pre-invasion setting in the early stage bladder trying to treat superficial disease. So we're going to have to find out over time whether TMB is an early, interesting biomarker that had its heyday and then yielded to other more sophisticated tests, or whether or not it's really one of those early discoveries that sustains and becomes carried forward as new treatments that involve checkpoint inhibitors are developed. And of course, that applies all to blood as well. So the development of biomarker assays such as TMB combined with PD-L1 and IHC and other tests are really having a major importance in most, but not all, types of genitourinary cancers. And the combinations of clinical and genomic data with immunotherapy biomarkers are designing newer and more sophisticated clinical trials, many of which are done right here at the San Raffaele Hospital, as we all know, to try to optimize the treatment for patients. And there is no more exciting time to be involved in this combination of genomic and clinical research to affect the clinical outcome of these patients with these sometimes devastating diseases that in the past we could do little for, and today we are having so much improved, a dramatic benefit for. Thank you very much. Mille grazie.
We were so enjoying so much, we started talking to each other about so many different possibilities of TMB measurements. My personal experience, patients who have high TMB, they also have more immune-related side effects. Now, I'm intrigued by the fact that the immune-related side effect should be host-dependent. It should not be the TMB of the tumor dependent. Do you have any thoughts on why and I'm not sure what other people think, and these patients get less ICI therapy. So people who have complete response, they respond after 6 months, we stop ICI therapies in those patients. So why do you think, if my observation is correct, why do you think high TMB patients have more immune side effects?
Our top hypothesis is the answer lies in the HLA genotyping, and which we do now, don't report, but we do on every patient. And we're trying to evaluate that as we get the data and then put it into the Flatiron database. But we think that certain HLA haplotypes, genotypes, patients more often have high TMBs when they have cancer, and then they more often have endocrine side effects, or even sometimes, bowel-based side effects, and sometimes skin as well. But it's much more the endocrine, I think, that we see.
Jeff, that was a great talk, very inspirational. I have a question about TMB being a dynamic biomarker. So do you think the tissue testing, are there any advances in the blood-based testing and how it evolves over time? And how, also the second thing about, there was a TMB harmonization initiative that was started many years ago, but we have not, the blueprint I think it was called, or we have not seen any updates on what other companies are doing for TMB, because right now this is the only FDA approved cutoff, so wanted to get your thoughts.
Correct. I mean, the dynamic is beautifully shown in the original keynote trial that got the MSI high approval for TMB that was all based on colorectal cancer only and then spread to all tumor types. For high MSI colorectal cancer, the TMB range is extraordinary. I mean, these patients all don't have 20 or more. You have patients with even as low as 10 and they're still MSI high, and then you have patients with MSI high who have 200 TMB. And when you look at the clinical outcome, the TMB so much outweighs the MSI status, meaning an MSI high but 10 rarely benefits from checkpoint inhibitors, but a TMB of, I think the cutoff we published was 32 and higher, MSI high in colorectal had 100% chance of a long-term durable response to the checkpoint inhibitor. So clearly it's dynamic, and if you picked 10 in that setting, you'll have a whole bunch of patients who aren't really going to benefit that much. But if you pick in MSI high, if you pick 32, you'd get all the patients that would benefit. But you wouldn't want to deny the patients who were below 32 a chance to benefit, even though their odds were much lower. So this is the world where we find it, and we have to keep trying to find that magical additional biomarker that makes the others make more sense. And we thought it would be PD-L1 stain plus TMB, but it's just not worked out. So we're still in the hunt, but I still believe pretty strongly that HLA subtyping could help us pick the patients most likely to get various side effects from TMB treatments, especially the endocrine, especially the hypothyroidism, because we found a lot of patients who's complain that the treatment they're getting isn't working and they don't feel well. And yet their scans and maybe their blood biomarkers are saying, you're doing great, you're getting better, your tumor is shrinking, we can't see it anymore. And the patient says, well, I feel terrible on checkpoint inhibitor, and we're forgetting to do TSH and show the patient's not symptomatic from recurrent cancer or progressing cancer. They have hypothyroidism that's not being detected because they're on a checkpoint inhibitor, which causes it in a very high preponderance of patients.
We have a question from Dr. Nardini, please. We need a microphone.
Yes, please.
Hi, thank you very much for the wonderful talk. I had just like a quick comment on what about the quality of the TMB in terms of what kinds of mutations that compose the TMB and how much would this impact on the responses, especially for instance in cases of patients with borderline TMB values. And also you talked about dynamics of TMB in terms of time, but what about space? Is there heterogeneity in terms of TMB within the same tumor across different areas? Is it a clonal, subclonal issue?
So for the final question first, absolutely heterogeneous. When we've looked at, and we published a study of prostate cancer, we studied of squamous cell carcinoma, all GU tumors, metastatic sites have different TMBs than the primary tumor, but of course it has to do with when was the sample obtained. So we could say, well, the liver metastases in prostate cancer have a higher TMB than the primary tumor. Well, that's not going to be a surprise. There's been a lot of treatment between the first needle biopsy and the subsequent metastasis biopsy. On the other hand, for some other tumors, it does stay pretty stable. I mean, clear cell renal cell carcinoma has low TMB at all times during the course of the disease. It never changes. But other tumor types are really impacted by the treatment. So it is heterogeneous, and I don't think that's always natural. I think that's therapy response associated. As for the other question, I'm not sure. I think we have a lot of work to do for sure. It's just come out. We don't classify the VUSs that make up the TMB score as to different weight. This one, VUS, is in an immune pathway. This one isn't. I mean, we have biomarkers like STK11, you know, that colorectal cancer-associated familial disease, Poitz-Jaeger, that's also a somatic mutation, particularly in lung cancer, where we've shown that tumors with STK11 mutations are very resistant to checkpoint inhibitors, but they've almost always are often KRAS mutated as well. And there are now companies making STK11 inhibitors, trying to restore STK11 function, which does involve lymphocyte tracking, in order to precondition a patient with lung cancer who's going to get a checkpoint inhibitor to overcome the STK11 associated resistance. So that's an example of one that we show trying to moderate the impact of TMB.
So thank you. I think we have to move on. Thank you so much. So let's move to the last presentation. Professor Russo from New York, new therapeutic technologies to treat GU cancers, rebuilding the immune system to counteract cancer.
The organizer for inviting me here to attend and present, and also Andrea Necchi for including me in a very active WhatsApp group. Thank you. I also feel that probably I'm going to crash this party because I'm not going to talk about GU cancer. I'm going to talk about brain cancer. However, we do believe that what we are seeing and the working hypothesis on the technology that we are using could be quite useful in renal cancer and bladder cancer. So at the end, I hope you guys will give me your view, whether you think what we are finding in brain cancer may be relevant. So I want to start by saying that the technology that we are using is a very, very well-proven technology, because in this institute, Professor Naldini, Tijet, and his colleagues have been using the technology successfully to treat more than 120 rare disease patients in collaboration with the hematology group here at San Raffaele of Fabio Ciceri. So we are working on something that it is very, very well characterized in the clinic. What is different is that we are not to try to address a monogenic disease, but we're trying to address cancer. And obviously, there are huge differences between this approach. What we believe is that the cell therapy that we are developing could provide with a single dose a solution and a durable response for many types of cancers. And I'll go through the reason for that. I also want to share with you the rare disease work done here in San Raffaele already resulted in 2 approved gene therapy products. And the first one, Strinvelis, was the first ever ex vivo gene therapy product approved anywhere. So we are very confident we are working with a very strong scientific basis. And I want to explain to you why we believe there is a room for a cell therapy approach in immuno-oncology space. Because this morning, we have been talking immuno-oncology, but not very much on cell therapy approach in immuno-oncology. And the reason is that there's been tremendous success in cell therapy, but only to limited set of cancer, basically blood cancer. And what are the reasons? We showed 3, in my opinion, significant challenges that need to be addressed. The first one is the durability of the response. Even the success in leukemia lymphoma, the majority of the patients after 4 or 5 years are relapsing. So the durability of the response remains still a major challenge. The second challenge is that we're talking about solid tumors. And as you know, when you try to treat a solid tumor systemically, the therapeutic index in the tumor is limited. And this has been a major limitation. Why? Because the systemic toxicity associated with high dose provided to the patient systemically, we would really prevent to reach a therapeutic index. So reaching the solid tumor, it is a major challenge. And I just mentioned the systemic toxicity, and I'm going to show you the technology we are developing that should address all 3 of these challenges at the same time. In the end, what I'm going to be showing you the ability to switch a cold tumor to hot tumor. So let's start with how do we reach solid tumors? We reach solid tumors by using a subset of monocytes. They're called TAMs. And the TAMs seems to be preferentially localized within solid tumors. The reason why we believe the TAMs are localized within the solid tumors is because the TAMs express a receptor called Ty2, which is a receptor for a vascular growth factor. So the presence of the TAMs allow the tumor to create new angiogenesis and grow. In addition, the Ty2 monocytes already have been described as the main culprit for keeping the tumor cold and suppressing the immune system. So what we are doing, we are using the Ty2 monocytes to deliver to the solid tumor a therapeutic gene, and we are using alpha interferon. So if you look at the cassette has the 3 major elements, the promoter in red, which is giving the specificity of the transcription. So the transcription will occur only on Ty2 positive cells. Then we have the gene of choice, the alpha interferon in green. And very importantly, we have inserted a sequence in blue that is a sequence homologous to a microRNA. And we choose microRNA 126. I will explain why. What happened is that, the microRNA are regulating the post-transcriptional events in gene expression. So what happened? In the stem cells, which are the cells which we are transplanting back into the patients after the lentivirus vector transformation, we know the stem cells do not express microRNA 126. Sorry, I spoke wrongly. Express high level of microRNA 126, and you can see here the microRNA 126 during the differentiation of the cells decrease, and when you reach the monocytes type 2 positive macrophages, there is no microRNA 126 expressed by those cells, which then means that the gene, the alpha interferon gene, is expressed where it is degraded when the microRNA 126 is present in the stem cells. This will avoid the toxicity that will be associated with alpha interferon expression in the bone marrow. So how we make the product? The product is basically the collection through apheresis of CD34 positive cells. Using the lentiviral vector, we in vitro transduce the cells with alpha interferon gene. The product is frozen, and when the patient is ready, is injected IV into the patient. The bone marrow stem cells will generate the progeny of cells, the type 2 positive monocytes, which will infiltrate the tumor and will have a two action. The alpha interferon will be released, and you have an apoptotic lysis of tumor cells. And in Nature Communication 2018, it's being shown by the group of Professor Naldini that you break intolerance, and you're inducing the activation of the immune system with infiltration of the tumor with CD8 T cells, tumor specific. I think the great characteristic of the product is the agnostic nature. And this has been demonstrated in many preclinical animal models. You see here glioblastoma, breast, lung metastasis, the colorectal cancer metastatic to the liver. You can compare the MRIs of the animals with the tumor to the MRIs of the animal treated with Tenfron, and the results are incredibly impressive. This is not only in solid tumor, but also in the B acute lymphocytic leukemia and multiple myeloma. So the agnostic nature tells us that the mechanism of action is indeed to reprogram the tumor microenvironment and allow the immune system to see the tumor. Now, we have a preclinical data that are being published recently showing that indeed the reprogramming of the immune or the tumor microenvironment results in a pro-inflammatory gene pattern associated with the release of interferon alpha. And by single-cell RNA sequencing, the very, very clear data is the ability to switch the microenvironment myeloid compartment from the immune suppressive M2 hypoxic monocytes to the M1 pro-inflammatory monocytes. So you see the difference between the control animal and the animal tested with alpha interferon. Basically, the disappearance of the hypoxic monocytes and the increase in M1 inflammatory monocytes are allowed to break tolerance, allow the immune system to generate an immune response. These data are quite impressive because they show you the long-term efficacy is mediated by the immune system, because you can see in an inducible model that yes, you can extend the life of the animal, the overall survival curve, but also when you block the expression of the alpha interferon, you still have the resistance to a tumor challenge, which then means that the immune system is now controlling the tumor. So you can see in MRI the data they show you there. You see that 115 days you have disappearance of the tumor, and then when you re-challenge the animal, you still have no appearance of the tumor. So it is immunologically mediated resistance to the tumor. We are doing a study. The study is done here at San Raffaele Hospital and the Besta Institute in Milano. It's the classical. There is any water somewhere? Can I have some water? I'm getting dry. No, it's okay. You don't need it. Thank you. This is the classical gene therapy study. Is a small number of patients, different cohorts. We start with 0.5 million of Tenfron per kilo. And keep in mind, in gene therapy, you cannot do even a phase 1 study with a product that you know that potentially will be not efficacious, because we're not going to be able to remove the product. Therefore, the risk-benefit need to be adjusted, and the 0.5 million tenfron per kilo, at least preclinically, have some evidence of potential benefit. We are in cohort 8, 4 million tenfron per kilo, and I believe this is most likely is going to be the top dose that we're going to move in a phase 2 study. In order for us to transplant tenfron, the product, you need to condition the patient. Meaning you need to use low-dose chemotherapy to create space in the bone marrow. We tested several different types of chemotherapy, and we decided to move forward with the busulfan in cohort 7 and 8. The study is a phase 1 study. As I said, we will be starting a phase 2 study sometime in 2024. The patients are newly diagnosed patients. In other words, they are basically, for us, first-line treatment because the patient only receive surgery, and the reason why they are not receiving chemotherapy because we are selecting unmethylated MGMT GBM patients that are completely refractory to temozolomide, which is the chemotherapy of choice for this disease. We will, in the phase 2 study, select complete resection, but for the phase 1 study, we did not. It is wide range of the age in the population, and we have the data that show the procedure, the transplant is safe because as expected you have the decrease of all hematological cells in the bone marrow, neutrophil and platelets here, but then you see within 7-10 days you rebound within normal ranges. So the procedure to transplant the patient in the GBM patients is safe. And importantly, we can look at the durability of the response because we can look at the vector copy number on the cell in the blood that they are progeny of the transplanted one. And you can see in the cohorts with the higher dose, even 540, 720 days post-transplant, we are above the threshold of 7% that was defined by the preclinical data in terms of what was efficacious and what was not. The safety is shown in this slide in terms of the systemic safety because, yes, we can measure in all the cohorts of the patient the alpha interferon, but look, we are measuring the alpha interferon of picogram per ml, which is way below any threshold for a potential systemic toxicity. If we were to dose the patient IV with alpha interferon, we'll be measuring microgram per ml. So we are quite confident that the systemic toxicity is not an issue in this approach. Now, this is the overall survival as September, and we have few patients that survive longer than the 15 months on average that there is overall survival in this patient population. And we have here the overall survival and the PFS at 17 and 8.3 months from surgery, 13.4 and 6.4 from tenfron treatment. Somebody mentioned about the cyclist in the study. On other study, I can tell you the patient number 25 in our study, which is one of the most recent patients, ran a New York City Marathon this month. I cannot claim there's anything to do with tenfron. Now, what I think is telling us that we are going in the right direction, although we cannot make any claim in terms of overall survival of this patient population, is looking at the survival of 2 years. And although I recognize it's only 5 patients out of 18, I can say that 28% overall survival at 2 years is significant, it's encouraging, let's put it in this way. If you compare to the overall survival and historical survival, although this is an older study, 14.8 and 18% in a more recent study. However, the 18% here do not discriminate between methylated and unmethylated GBM, and therefore this number is lower if they were to look at the unmethylated GMT patient population. So we think we are in the right direction, and we hope that we'll be able in the phase 2 to have a little bit more robust data in terms of the clinical significance of the treatment. Now, the alpha interferon seems to be correlating with the dose. Higher dose patients have a higher percent of patients expressing interferon alpha. We can also see interferon alpha in the CSF, and there seems to be a correlation between the presence of the interferon alpha in the CSF and the relapse of the tumor, and I'll explain this in a minute. And then we also see that the signature, the interferon signature, in a tumor from the second surgery, those are the patients that have been already treated with Tenfron, is showing a pro-inflammatory state. Now, the major limitation of this study is that we cannot assess the tumor microenvironment in every patient because we do not have the possibility to sample the tumor unless the patient go into progression, and then there is a second surgery. So that is the limitation of the study that we will address in the next indication. Interesting, the T cells, there was some discussion about the T cells. I think the data, we're working with Adaptive, a company in the US where they are sequencing T cell receptor and we are assessing the clonality. So you can see that there is a slight increase in T cell clones in a patient after Tenfro treatment. The decrease at 30 days post-transplant is due to the chemotherapy, the conditioning. Interesting enough, you can see if you compare the tumor from the first surgery with the second surgery, you can see that the clones that were present in the tumor, but they were most likely anergic. Somebody was talking about what we know about T cell energy, and we see that after treatment there is a clonal expansion of those clones, but also there are new clones that were not present in the tumor of the first surgery that appears in the second surgery and seems to be expanded. Those are data that reproduce what we see in the mouse. Now, the data that make us very excited are the single-cell RNA of the myeloid and T cell compartment, and we are comparing 5 Tenfron-treated patients with the 6 standard of care treated patients. And what we are seeing is that if you look at the gene expression, there is a broad upregulation of genes associated with the interferon, inflammatory, hypoxia, and there is decrease in gene associated with cell proliferation, both in the myeloid compartment and in the T cell compartment. So this type of data also in the tumor, looking at the CD34 negative tumor cells by single-cell RNA, it's shown the same thing. It's shown that there is downregulation of proliferation of a variety of different neuron cells and upregulation of interferon genes. So, in conclusion, we have a biological evidence of the activity of Tenfron on modify the tumor microenvironment. However, we do not have the correlation between this biology activity and the clinical progression of the disease. And the question is, are we not seeing the disease modification because we are still under the therapeutic index? And this is what we believe is most likely the case. I show you the data from the low and middle of the dose ranging study, but the study from the data from the most recent cohorts, 4 million, will be sometime next year. Very quickly, this is very important set of data from the longest survival in our study. These patients survived more than 3 years. And what is peculiar is that after surgery, there was a very fast tumor progression just before the patient was treated. Then the patient was treated and the patient was stabilized. The patient, the tumor did not grow, clinical condition of the patient improved significantly, and the patient did not receive any second-line treatment. The reason why we think this is quite important is because if you believe the burden of disease is recruiting the effector cells, the type 2, we are starting in patients that undergo surgery, so we reduce the tumor burden, and therefore the migration of the type 2 in the brain may be slow. In this case, you see a very fast recurrence after the first surgery, and we believe this correlates with the stability, the ability to recruit temps and to stabilize the disease. So, in conclusion, safety is good. We have no dose-limiting toxicity associated with the treatment. Does not mean that we don't have a serious adverse event. We do. They are all associated with the bone marrow transplant procedure, and we are managing accordingly. Tolerability, we have no systemic toxicity associated with Tenfron, and I show you the biological activity make us believe that will make sense to proceed. And now the reason why I'm here. The reason why I'm here is because working with our colleagues at OSR in GU, we are working on testing Tenfron in renal cell carcinoma and urothelial carcinoma. We are also encouraged by the approval of this drug here that in essence is alpha interferon, and this drug is being given to the patient by catheter, and they show a tremendous response. You see a complete response in 51% of the patient with in situ carcinoma by 3 months. So the interferon alpha seems to have a profound effect on allowing the immune system to see the tumor by reprogramming the tumor microenvironment. This is going to be the study, which is not very different from what we've done in the GBM. Basically, patients are recruited. Obviously, the difference here is that we are not going to go on first line or second line. We're going to go in patients that are not responding to second-line treatment, basically don't have very much other options. This is going to be a challenge because we need to be assessing the competence of the immune system in those patients. They've already gone through several types of treatments. And then what is the reason why we really want to work on a tumor that will allow us to have a biopsy in all the patients before and after 90 days post-transplant. And that will allow us to have a much more robust tumor microenvironment data to assess the effect of Tenfron. And I know we are late, so I'm just going to say thank you to the people that have done the study. As I said, the study is done here. San Raffaele is also done at Besta in Milano. TGET is the source of the science that we are doing. We have a Gemelli, and then you can see a long list of other institutions that are really interested to work with us in phase 2. Thank you very much. We have seen the alpha interferon, but as I show you, very, very low level in the blood. The measurement of the alpha interferon in the tumor is only possible when we have the tumor and patient going to relapse. So I'm not sure I can answer your question. Obviously, if I may, the key question here is what is the possible long-term safety concern having loaded monocytes with alpha interferon years from when you transplant the patient. Obviously, this is not a problem in patients that die within 16 months. But if you wanted to apply this to a different type of population, which potentially have a much longer survival, then is something that we are going to be addressed. And we have here Professor Naldini that is working on a switch-on, switch-off approach that will allow us to modulate in vivo the expression of the alpha interferon gene. So that's what we're going to do. By the way, before I said Dr. Naldini, I did not recognize the voice. I guess there are two Naldinis here.
We are lucky we have not only one, we have two.
Two.
So if there is no other question, we are really late. We apologize for that. We have 20-minute coffee breaks and then we come back here. Thank you. Just to say that during the coffee break, there will be a Parinuri Association showing videos and at your disposition for any kind of questions. Thank you.
Della vescica, un segnale può salvarti la vita. Fermati al rosso.
Sì, pronto, scusatemi, sono Fabio. Ho una piccola emergenza, devo annullare la riunione. Sì, ok, grazie.
Prova. Cioè solo che...
Qual è il problema? È che il tecnico ha tutto.
E. E. Prova. E.
Parlare bene il microfono, quello è il pointer
Guarirai e del male ti libererai. Non lo senti questo amore che è più forte del terrore? Ci sarò, con l'amore io ti guiderò, come un angelo di Dio che non vedi. Guarirai e del male ti libererai. Non lo senti questo amore che è più forte del terrore? Ci sarò, con l'amore io ti guiderò, come un angelo di Dio.
Sì, la sento.
Sì, sì, ve l'apriamo noi da qua. Un secondo, mi scusi.
Okay. Good morning to everybody. We are ready to start with this very interesting session about an overview of the most established and important ongoing academic partnership with national and international partners. Each speaker will have 15 minutes for the presentation. And the first speaker is Lars Diskjot Andersen, that I invite on the podium, with a presentation entitled Circulating Tumor DNA Use in GU Cancer. In the meantime, I want to thanks a lot Andrea Necchi, Alberto Briganti, and Francesco Montossi for the invitation, and it is a really pleasure to co-moderate this session with Andrea Bellone and Angelo Corti. I think that we are ready with the presentation.